Hello, everyone, and welcome to our last session of day 2. My name is Tina Costa. I'm one of the directors with the PHSA Office of Virtual Health, continuing to be your host for these virtual sessions. My pleasure to welcome you or re-welcome you to the end of day 2 of the 2023 BC Digital Health Forum. For those of you who are just signing in for this particular session and joining our virtual circle, we encourage you to share in our collective gratitude for the opportunity to come together from many traditional, ancestral, and unceded territories of BC First Nations. And as we continue to engage, learn, and collaborate in the realm of digital health, let us give thanks for the privilege to do so on these beautiful and sacred lands. And may our discussions contribute to a future where Indigenous voices are uplifted and the principles of reconciliation guide our path forward. I now have the pleasure of introducing our next presenters, Dr. Andre Kushniruk and Dr. Elizabeth Burecki. Dr. Kushniruk has a PhD, obviously by the doctor. He's a director and professor in the School of Health Information Science at the University of Victoria. He conducts research in a number of areas, including evaluation on the effects of technology, human-computer interaction in healthcare, and usability engineering. His work is known internationally, and he has published widely in the area of health informatics, cognitive science, and artificial intelligence. He focuses on developing new methods for the evaluation of information technology and studying human-computer interaction in healthcare. He holds undergraduate degrees in psychology and biology, as well as a Master of Science in Computer Science from McMaster. He also holds a PhD in cognitive psychology from McGill University. Dr. Burecki is a professor in the School of Health Information Science, and she is the Director of Global Laboratory for Digital Health Innovation at the University of Victoria. Dr. Burecki is a Michael Smith Health Research BC Health Professional Investigator. Her research and teaching focuses on human factors and safety, systems design and implementation, technology evaluation, and virtual care. Dr. Burecki is a fellow of the American College of Medical Informatics, the Canadian Academy of Health Sciences, and the International Academy of Health Informatics of the International Medical Informatics Association. Without further ado, I would love to introduce both Dr. Kushniruk and Dr. Burecki for their talk on human factors, AI, and safety.
Okay, thank you for the introduction. The talk is human factors, AI, and safety. I'm going to focus in the first half hour on human factors and AI, and Dr. Burecki will then focus in the second half of the presentation on the safety aspect. So I've worked in both areas, human factors and AI, initially quite a while ago working in the field of AI generally in industry and academia, moving to human factors and then eventually into healthcare. But I've known along the way that there is a long and intertwined history between human factors and AI. This is why the talk on the combination today. And from what I've seen over the years, I found that the success or failure of AI applications in healthcare was very closely related to usability and how well the systems actually fit with workflow. And along those lines, I want to talk about some methods that are available for increasing the chance of success in adoption of AI. And also looking at considerations of how to best integrate AI technology with humans. And so I always like to begin with what is human factors as a field. And this definition has human factors as a scientific discipline concerned with understanding the interactions among humans and other elements of a system in order to optimize human well-being. And here, systems can be seen broadly. Could be a technology, could be a medical device, a person, even an organization, and also, of course, including could be AI systems. As a subfield that I worked in for many years is human-computer interaction as a subfield of human factors. And my favorite definition comes from the Association for Computing Machinery that says HCI, or human-computer interaction, is a discipline concerned with the design, evaluation, and implementation of interactive computing systems for human use and the study of major phenomena surrounding them. So you'll see today how this colors my perspective on looking at AI in healthcare. Just as some further background, when considering designing any systems in healthcare from a human-computer interactive perspective, and I've worked with decision support systems, electronic health records, mobile, many applications. One of the things that really hits you is the complexity of healthcare. There are uncertain information, ambiguity, and many of the problems are what we call in psychology ill-structured problems. Some are well-defined, but many are ill-structured. We'll come back to this point. There's a lot of local needs and variation in healthcare, and complicating matters is there's many and varied use cases of systems. So we can say that arguably healthcare is probably the most challenging area for integrating any advanced technology, let alone AI. And as I mentioned, I've worked in this field for a while, but the history of AI in healthcare goes back even farther back into the 1970s. I got involved in the latter part of the 1980s, when there was a whole lot of development of expert systems at the time. And what happened, there was development of many systems, thousands of them at that period of time. Most of them, however, stayed as prototypes or pilot systems. And around that time in the 1990s, I think one of the most interesting papers I read was called The Demise of the Greek Oracle Model of Medical Decision-Making. And that was the idea that clinicians didn't want their decision-making replaced, but rather supported. And that they would like a system that was a catalyst to help solve problems in their own workflow. And from then on, I figured the issue was a human factors issue on adoption of AI. And the implication was we needed to understand cognitive processes and where systems would fit in. And that was a period that was termed at the time an AI winter, and many of us modified our careers at the time. But since then, AI has had a lot of successes. And I always like to say AI isn't one technology, it's many technologies. And they've really advanced over the past 40 years. If you're following what's going on, many of the applications now that are discussed are based on artificial neural nets and deep learning systems. And again, those have roots in AI research labs. The one I worked in Toronto in the late 1980s was one of the first ones for working in the neural net area. And it took decades later for the computational power to become good enough to have them applied in many, many applications now. But again, there are many different technologies. Machine learning and data mining has made a big comeback. Natural language processing, speech recognition. We could go through a whole list, predictive analytics. And from my perspective, even things like predictive monitoring of ICU patients and intelligent bedside monitoring also fall under the rubric of AI. And of course, we wouldn't even be able now to be doing work in bioinformatics or genomics without it. Many promising applications of AI in healthcare, and all of these are at varying degrees of adoption. But the ones that are generally discussed as being success or beginning to be integrated include radiology with automated pre-processing of images, dermatology. I'll talk about an application I worked on about a year or two ago later in this presentation. Many other areas, pathology for image processing and collection and archiving of images, cardiology for predictive analytics and alerting of patients of potential cardiac events ahead of time, and psychiatry and psychology with automated consultations. Other areas have brought AI in a different modality. For example, robotic surgery, the very impressive Da Vinci robotic system. Other areas, documentation, this is an area that was left for a long time. How do we reduce previous documentation using AI? And I'm glad to see companies are coming out with systems and approaches to doing this. In looking at, one of the ways I've looked at AI over this period is where have applications been most successful? And what I found is AI, the current form of AI that's predominant, excels at what we would call well-defined tasks, particularly artificial neural nets. And I have to say less so with what are termed ill-defined clinical tasks. So, for example, identifying if an image is malignant mole or not, we have systems with high accuracy rates on that type of thing. But there are a lot of other tasks and activities in healthcare that are much less well structured. When AI has been most successful, it's held a supporting role, not intending to completely replace humans in the loop. And it also has a real potential for supporting poorly resourced services, things like AI-based chatbots, and getting healthcare out to places if we don't have enough family doctors, being able to access like Palace's applications and previously called Babylon. So a lot of potential, but the models and systems have to be adaptable and updatable. And having worked in AI for a while, I always like to look at Getner's, they come up with this every year hype cycle for artificial intelligence. If you're not familiar with this, Getner has hype cycles for most technologies. And what they do is they place on a curve there people's expectations on the y-axis of new technologies. So starting from the left-hand side, new technologies come in, and then at some point, and we've seen this over and over again, they reach what's known as the peak of inflated expectations. And on this one, they've actually located at the top of that first peak generative AI that would include things like ChatGPT and smart robots. Over time, there's often a little bit of a disillusionment about the systems didn't exactly deliver what was expected. Then it falls into this trough of disillusionment. Eventually, systems that are useful, and there have been many useful ones that have stood the test of time and advanced in AI, you follow up along the slope of enlightenment to the plateau of productivity. So a lot of the type of applications that are marked in there include computer vision, data labeling, annotation, and intelligent applications, and interestingly enough, they located autonomous vehicles there. But I'm not sure if I would have put them on that part of the slope yet. So as I said, the AI has been around for a while, and there were a number of issues with AI pre-2000, and I recently did some papers on were those issues still there, or have they been modified over time with new applications and new technologies of AI? Well, one of them that was there all along and still is there is issues of trust and liability. This is where human factors really comes in, to be able to analyze what happens if AI makes a mistake. And in human factors terminology, that's called looking at failure modes, comparing human versus machine error modes, and trying to analyze what issues are with both. A second issue that has been considered before and still today is the whole issue of knowledge acquisition. Earlier types of AI were rule-based systems, and the issue was how do we obtain and update rules for the knowledge base. Currently, we've moved to machine learning with different types of data sets, and the same issues come back in a different way. How do we ensure that the data sets are accurate and not biased? Another issue that came up, it was back in the 80s, I remember, was how does the system explain itself? With a rule-based system, it will often provide the information of what rules it used. With neural nets, this has become a whole research area because it's a lot more difficult to show how a neural network has come up with an explanation. And the other issues often human factors is what's the mode of interaction of the system with the human? Is it embedded or ubiquitous, or is it an interactive system? Another issue I documented that still remains is challenges of integrating new technologies, including AI, with existing software systems and work processes, and leading to the issue of generalization. Often systems were working really well in a location where there was a publication on the efficiency or accuracy, but often didn't generalize outside of that domain. And lastly on this slide, the whole idea of when does a system need to cut out and go to either human or to an underlying system that supports common sense reasoning. So there's still many areas that verge on research. The area that I focused on, and Dr. Bricky will talk about as well, is the need to improve risk and safety evaluation. And what I found, there's been a lack of work on evaluating systems in the naturalistic environment, what I term the naturalistic evaluation. And that would lead to a better understanding of that area of failure modes. So a number of issues remain, which makes this, from my perspective, a very interesting area through a human factors lens. I'll just give an example of that. There was a system some of you may be familiar with, IBM Watson Oncology, and I was familiar with this because in 2017 I was asked to do some evaluative work on this system, and at the time I was surprised that it had been put out and there was a lot of evaluations of the accuracy of IBM Watson, but very few studies of how it actually would work or integrate within clinical settings across hospitals in the US and other countries. And at that time, there was also reports coming out of some of these same issues, like I think they changed their EHR at the time, didn't integrate well, and they had issues around fitting the system into the workflow once the EHR changed. So these are kind of things that come up over time and underlie the need for understanding human factors. So I always like to look at things from a solution point of view, and from my perspective, that comes from looking at it from a human factors and usability lens. And we've done usability studies probably on hundreds of different systems, and AI is yet another type of system we've applied and modified our approaches. But I always like to think about initially in presenting this, what is usability? And the definition I like looks at usability as a measure of learnability. That is, how easy is it to learn or not how to use a system? Its effectiveness, is it accurate? Does it do what's expected? Efficiency, does it do it, but does it take 10 times longer than we should? User satisfaction, and in this definition, included safety as an important part of usability. And we'll see with AI, this also becomes an important consideration. So our work involves usability testing, and I've written many papers and worked on many projects on this, not just on AI applications, but on advanced health technologies around the world. And usability testing is a simple concept. It's observing representative users doing representative tasks, typically done by video recording, user interactions, audio verbalizations, and looking at people solving problems using the technology. The other approach, and Dr. Bricky will talk about how we have developed labs to conduct what we call clinical simulations that expend this observing representative users doing tasks with representative or real scenario situations or settings. And this is really where we want to understand how systems fit within a workflow of healthcare processes. And I have it on this slide simply as there's a continuum of fidelity of testing systems from the laboratory at the left-hand side, moving to clinical simulations in the middle, and testing things in the naturalistic or real environment. And in our work, we often move from the left-hand side to the right-hand side or back. It's kind of depending on how the work is going. And I won't spend a lot of time on this. This was just a model that we've developed that worked well for when we have to diagnose issues with systems from a human factors point of view. Generally, we like to start at the bottom and analyze users interacting with the system in isolation to identify surface level usability and other problems that could be easily solved. And we've applied this in looking at all kinds of systems, including AI, reminder systems, and other types. You can optimize the system at that layer of level 1 but it won't guarantee the system will be adopted. So then we typically move up and conduct studies at level 2, where we're doing clinical simulations of the technology that mirrors or is actually the real situation. And then, of course, there are multiple layers above this, looking at how users interact with systems within an organization. And then on the right-hand side, I just listed some of the methods that we've used or developed. I'll just give one example. This was a digital supercluster project we were involved with a number of organizations in BC, dermatology point of care intelligent network for early diagnosis of skin cancer using machine learning and AI. And the objective was to integrate an AI-based imaging system into healthcare. And what we found, the companies involved had already developed very accurate technology that greater than 90% accuracy in identifying cancerous moles. But at least from our issue, we were sort of tasked with looking at how the technology could be integrated into primary care. And the motivation for this was, of course, the wait times for specialists, and when we're dealing with cancer care, days, not even months, but days and weeks make a big difference. So the technical solution I won't get into was uploaded photographs of moles from the GP's office, and then they were almost instantaneously compared to labeled images of types of moles that were labeled as cancerous or not, and it allowed the GP to send the report to the dermatologist remotely, just by clicking. So it allowed for support of risk analysis and telephone triage. When we're looking at an application like this, you can develop a workflow map of all the different places technology could be inserted. And in cancer care, there are so many different places where the different technologies could be inserted. But this project was more at the front end, looking at reducing the up to 6 months wait time from the private care exam to the specialist. So using that tool, when we did the evaluation, the time between referral to the dermatologist was cut from, I think it was 192-day average to, in most cases, less than 5 days. It's a bit hard to tease out whether the positive effect was from the telehealth aspect or the AI, but both were positively rated by the clinicians and the patients that we interviewed as well. So we had statistics and qualitative. So the implication is not to replace diagnosis, but to flag potential cancers and speed up timely treatment. So that I thought was a good example of integrating systems like this in the healthcare, but it doesn't require that work in analyzing where does it fit and testing it. So I'll just end with one on how to integrate AI into health. Well, some comments. It must be inserted for a task that AI is proven to be good at doing, which includes accuracy. Inserting the AI at the right point in the workflow is critical for proper adoption. Considering how the system affects work practices, human reasoning processes, patient journey, and ultimately decision-making. So what we have proposed is that in testing AI systems that you do a phased approach where you start with laboratory-based usability testing, moving to clinical simulations, and then finally moving to live or near live testing. And we have papers and publications on this. The other thing that we worked on is classifying AI applications in healthcare in terms of human-computer interaction modes and criteria like, is it a consulting mode? Do people consult? There are many options here. Is it critiquing? Does the system critique a solution? IBM Watson Oncology could run in multiple modes. Does it augment human perception or extend physical access, like robotic surgery? And we could even consider advances in adding alerting and remindering into electronic records as an extension of rule-based AI. The joke was that if something became mainstream, it would be no longer called AI. So that's, again, another successful area. Also worked on developing a framework for classifying AI applications in health. If anyone's interested, just email me. Looking at 5 dimensions, including what the mode of functioning is, the mode by which advice is offered, the interaction style, the underlying decision-making model or engine, how it's actually running from a technical point of view, and last but not least, human-computer interaction issues. And just to illustrate that, interaction modes can be on a continuum from, on the left-hand side, consulting and decision support roles, to the right-hand side, autonomous, independent, or self-contained applications that may be ubiquitous or run in the background. And along the middle, we have applications that may be dormant until something happens, and then they come up like an alert or reminder. So, and just in summary, areas where AI is being adopted from a human factors perspective is where it makes life easier, providing healthcare workers with data that couldn't otherwise be obtained, or providing overviews of rapid decision-making that would otherwise lead to cognitive overload or take too long for human processing. As I said, intelligent monitoring at the bedside could fit in this category. So, in characterizing AI success from a human factors perspective, it appears AI will be adopted if it's shown to work properly and is accurate. Now, in the US, they have FDA approval of AI applications. In 2018, there actually weren't a lot approved at the time. I think it was about 50. Now it may be up to 500, but still not as many as we would think. And a lot of healthcare organizations, I was on a panel with hospital managers, will feel more secure if an application has FDA approval, obviously for liability reasons. The other thing I won't have time to talk about, but it's coming down the pipeline, is there's Bill C-27, I believe it is the AI and Data Act in Canada that's forthcoming for regulation on AI applications. And the details of that are being worked out, but there's a lot of a requirement for disclosure if your system made a decision using AI, and what data, where did the data come from, privacy and other issues. So some of this is coming into place in the Canada, the US, and also the EU as well. But that's a work in progress. If the system is useful, saves money or increases efficiency, or can do tasks otherwise not possible. Additional human-computer interaction issues. One of the other areas we're beginning to work with is human-robot interaction, which is a really next step area to look into. And with some of the successes have been with systems like the Da Vinci robotic system, which actually isn't autonomous. The surgeon controls it, but it has layers of AI built into it, and that's been very successfully used around the world for over a decade now. And we get issues then talking to designers of some of these systems of how much control does the system exert versus the human when we're looking at that balance. And some of these discussions were actually parallel to ones I've heard about in aviation with highly automated planes. And I'll just end with HCI and mainstream adoption. I'll be working with trying to bring some of the technology into the mainstream. And the argument here is that will require more practical and rigorous approaches to applying some of the approaches from human-computer interaction. And also better understanding the needs of different types of users, especially as patients and consumers begin to use AI applications like chatbots and symptom checkers. And some of you may be familiar with Rogers' diffusion of innovation model, where when new technology comes out, there's usually a progression of a small number of people, in this case could be physicians or nurses, innovators first to adopt the technology, moving to early adopters, the early majority, and then most people are using it at some point, late majority, and usually only a few people at the end having to be convinced. So it often ends up with this is superimposed on the normal curve and the S-shaped adoption curve. So we are looking at what the needs and values of users at different types of users in order to move that curve along and increase adoption of technology that is proven to be safe and successful. So, conclusion, I covered a lot in a short time, but the main takeaway is increased consideration of human factors, including methods, approaches, and frameworks, will be essential. It's not like AI is any different from electronic health records or other types of technologies, and does require proper rigorous testing and the modification of techniques that are suited to analyzing AI. And the extent to which the AI is found to be useful and usable and fit within human activities will be the main determining factor in its adoption. And with that, I will pass it on to Dr. Elizabeth Brickey, who will continue the discussion, particularly focusing on the safety aspect of implementing AI in healthcare. Thanks.
Hi, everyone. I'm really happy to be here today. Thank you for inviting both Andre and I to do a presentation on this topic area that is increasingly becoming important. And as a result, we've invested a lot of research and academic resources here in the School of Health Information Science. Today, I'm going to talk a little bit more about AI and safety to pick up where Andre left off. Okay, so we here at the school, in terms of looking at AI and safety, we very much take a learning health systems approach. Part of that involves defining what technology safety is, as well as some of the issues that are present and how we might go about solving them in terms of looking at the technology in the context of evaluation and testing. So what is a learning health system? This is actually a really important area of health informatics. Recently, the Agency for Healthcare Quality has really identified the importance of employing learning health systems. Chuck Friedman, who is internationally renowned health informatics specialist and academic and researcher, recently did a talk for us in our department. And what we did is we as a part of that, we also talked about some of this work that's been going on here. So what is a learning health system? It's a system that employs modern evidence-based quality mechanisms to create safe, high quality systems of digital healthcare. They involve the use of healthcare practices in which progress in science, health informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of care experience, and that is seamlessly refined to deliver best practices for continuous improvement in health and healthcare. So learning health systems are in fact a type of approach and way of looking forward in terms of improving the quality and safety of technologies. And as you know, when you're implementing systems, you have digital structures that you implement in an organization and you configure it for that organization. And then what happens is there are organizational activities and processes that it influences, as well as outcomes. And then you might add in additional digital structures, or you might configure that technology again to improve those processes over time and improve an ongoing process where we have perhaps unsafe systems of care, but we're constantly trying to move it towards a more safer type of system of care. Truly, we are, every time we move that orange button further and further over, we get to the point where there are few issues with technologies. And we can see examples of that in the aviation industry, where in the early 1900s, there were a number of safety issues that occurred with flying aircraft, but today it's one of the safest industries out there. And healthcare is the same way. We're evolving and we're improving in terms of our safety and our provision of good quality care. And as we know, healthcare has gone through quite a modernization process in the last 20 years. Today, we see digital care almost everywhere. Certainly when the 1950s and even at the beginning of my career, which is not that long ago, we were going through an implementation of varying different technologies across the healthcare sector. So one of the things we learned in implementing technologies is that we know that technology itself can reduce errors, but it also can introduce new types of errors. And that makes sense because we're introducing new processes and new ways of doing things. So we also have to consider that fact that health information systems and technologies and even integrated systems can also contribute to safety issues. So what is a safety issue? A safety issue, as we discuss in the School of Health Information Science, is a technology-induced error. And it's a type of error that arises from the design or development of a technology, its implementation or customization, interactions between the operation of the technology and new work processes, its maintenance, as well as the interfacing of more than one technology to support healthcare services. And AI is part of that because AI can be integrated into varying different types of services and at a broader systems digital ecosystem level. So to give an example, you might have a technology-induced error that occurs when there's incomplete patient information, and that might lead, for example, a clinician to give the wrong medication. Or you might have a poor display that might lead to someone prescribing the wrong medication strength or dose. So these are the types of errors that occur and in the technology safety literature. At the School of Health Information Science, this has been a focus of research and activities since 2005, so quite a few years now. And over those years, we've actually built out a number of different types of methods and tools that can be used to assess the safety of systems. And as you can see, we have created quite a few tools over the last few years, and we've developed layered approaches that can be used from the point of design and development of the technology through to its implementation and maintenance after it's been deployed. And these particular methods are extremely successful in finding issues and then correcting them as part of a learning health systems approach. So what can we say? Health technology safety is not a new issue. We can use some of our existing methods to actually improve safety of systems over time. And there is a lot of potential of artificial intelligence to improve health outcomes, and that we have to recognize that we have to work on this technology too over time. So where do technology-induced errors come from with AI systems? I think everyone can recognize this particular slide. This is from work that was done by James Reason. We've done some customization of this work for the digital health sector, but you can see that if you have some kind of failure that takes place and at different levels within an organization, you might have an error occur. And part of that might be differing and varying issues with the technology itself. So for example, if you look at the literature, AI has, and data quality, the data that's being used to train the system can be an issue. So for example, you might have non-representative data, you might have biased data, you might have discrepancies between the training and the test data set. There might be an insufficient size of training and test data sets, and this is a particular issue for Canada, as for some types of diseases, we don't have enough people to be able to develop effective training and test data sets. There's some interesting research where in some cases, you actually have to look at multiple different countries to be able to create a data set that's large enough. We might not be able to fully handle noise in the data or statistical outliers. And there's also research to suggest that letting the users control the data alone may lead to some types of errors occurring. From an AI designer's perspective, I think there's a number of different areas that need to be considered. So for example, specification is really important when working with AI. So for example, an informal specification may lead to errors occurring, poor specification, or even a wrong specification. And sometimes designers, depending on their backgrounds, may create an objective or task for the algorithm that may unexpectedly produce results that that lead to a particular issue that need to be addressed. And these are the types of things you need to consider when you're designing technologies. One of my favorite ones too is when you look at these types of solutions, you should really consider what you already have out there and whether or not it's successfully performing what it needs to do. So, it's kind of interesting. Some algorithms actually perform better than others. There's oftentimes a history to using particular algorithms. So you need to conduct head-to-head tests of algorithms to make sure that they actually are effective and perform better than what you already have. There are also other things that need to be considered when looking at safety from a designer perspective. So, for example, when moving a technology such as AI into a real world environment, there are certain variables that may not have been considered that are present in that real world environment that may lead to harmful things happening. So it's good to understand and control and look at how the environment that matches with what the designer actually specified in the original design of the technology. Other solutions other considerations that designers need to take a look at is, for example, things such as activities that may occur in the deployment of systems, such as gaming to achieve a particular result involving the AI or algorithm, and also looking at how the algorithm itself may actually influence what you do from an organizational perspective, because it gives certain, it may be created in such a way that it may reward the individual for particular behaviors. Other ways of dealing with AI and considering the safety of solutions, and this is really important, is actually looking at how you might test the solution to see how well it functions in a given environment. And one of the things that's oftentimes an issue is just determining the level and the amount of testing that's needed. So, for example, you might want to do some testing around where extreme conditions, usability and usefulness of the algorithm or the AI, and the work and how it's actually integrated from a workflow perspective. So the example that Andre gave earlier in and around deploying a AI technology for looking at moles, one has to consider how it fits in the healthcare system and where it's most effective. And that's really important. That's part of testing and evaluating that new technology to see how it works. So implementation and deployment is also a consideration. It's really important to look at the quality of the algorithms. Some algorithms and AI are underperforming in terms of their work. In addition to that, you may have cases where there isn't a sufficient security mechanism to actually prevent anybody from tampering with the AI. Or you also have to look at things such as, for example, helping the users to understand how the AI works, what its benefits are, as well as its limitations, and what to do when they encounter a particular issue in terms of speaking to IT support. So how do we make technology safer in the School of Health Information Science? And this is a very important area for us in the next little while. So one of the things that we're doing right now actually is we've had some investment from the Ministry of Advanced Education, and we've actually built out specific labs that allow us to actually look at how one might introduce a particular technology into a clinical environment. So this is an example of our digital hospital room. In addition to that, we know that AI is being introduced into physician office and clinic environments. And so we've actually created a clinic environment where students are able to create different types of technologies and test them out in the context of what would be a typical clinic visit. We also have a smart home now. And here's a really nice slide where there's some teaching going on. It's actually Dr. Kushniruk speaking with two students, and they're looking at a telemedicine system where there's some communication taking place between a fictional clinical environment and a person's home. And this is our smart home environment, which has been instrumented with varying sensors as well as technologies that can be found in typical homes. So, for example, we have a smart fridge here. We also have we also can communicate to clinicians using our telehealth telemedicine approach. So I just wanted to mention we have both on-campus and distance training solutions. So we also have a lab that we've created that looks at different types of visualizations, as well as allows us to integrate individuals who are taking courses with us from a distance with those who are in the classroom. One of the few things that I haven't mentioned is the fact that our faculty do a lot of research. This is just a smattering of different areas that we do research in. In the last couple of years, we've been doing a lot of work in the areas of usability, safety and quality, user interface design and user experience, data analytics, and that we've had several grants in this area, simulation and monitoring, management informatics, implementation science, organizational behavior and change management, as well as other differing areas. So, and we've been partnering quite a bit over the last few years with varying different organizations internationally. So we're able to bring a lot of key learnings into the classroom, as well as into our healthcare system here in Canada. And those organizations have been academic organizations, as well as public and private sector organizations. And on that note, I'm going to just mention this is our contact information. If you have an interest in connecting with us about research, to collaborate on research studies, if you have an interest in connecting with us to take courses, or even if you have an interest in specific micro-credentialing around digital health, please connect and we'll be there for you.
Wow, thank you so much, Andre and Elizabeth. What an incredible wealth of information that you guys have both just shared, and such an interesting conversation. And just want to also say thank you to the both of you for the breadth of research that you guys are leading and being a part of, the collaborations and partnerships that you guys are making. I particularly really loved the dialogue around the need for models to guide and comprehensively test the interactions between technology and human to gain those better insights. I think that's definitely a learning space for myself, and probably many of us who still work in the clinical space. And lovely to see the super awesome learning labs that you guys have available and that you've developed. We do have a couple of questions already in the queue, so we'll go straight to those and encourage other members of the audience to write your questions in. The first question we have states, is it possible to build accessibility requirements into usability testing, such as UI UX design?
Oh yeah, absolutely. For accessibility, I mean accessibility for different types of users, disabilities, and that. Yeah, absolutely, and that should be in the requirements. One of the issues that has been a problem is just usability requirements in general. In contracts and things, even not getting into for disabilities or accessibility, but having better specifications of usability requirements. And there are ways to do this, but that's really important. Absolutely, yeah.
Great. Next question is, are there big differences in how scalable the different types of AI are? Or does it make more sense to develop a new artificial intelligence for each new use case or usage?
So for the scalability of like, it definitely is not one size fits all. And the other point is making, there's so many variations of, I mean, yeah, when they talk about AI a lot these days, they are talking a lot about artificial neural nets and deep learning systems, but there's many other types of systems and variations, and even some of the natural language processing systems are kind of a hybrid as well, not completely one technology or the other. And that's why in my classification I talk about the underlying engine, because how does that map to the type of application as one of the factors. So yeah, that's why I find some of the discussions when we see in the general public aren't really informed. They talk about AI as if it's one thing, is AI good for the economy or not? And having worked in the field for decades, it's so many different streams of technology that really you have to look at the matching the use case to the technology, which means knowing about the use cases and knowing about the technology, yeah, and its limitations and advantages.
Great, thank you. Another question here regarding failure to test for extreme or rare conditions. Well, context plays a role. How do you or can you reconcile this concept with the 80-20 or 90-10 rule? For example, designing a solution that satisfies 80 to 90% of use cases.
Well, I think in healthcare, and this is kind of an issue just in general around technology safety, is that in healthcare, we oftentimes do encounter rare conditions or unusual situations. And it's highly dependent also on the context of the patient population that is present in your organization. So you might create a solution or identify a solution that it covers off 80% of cases. But once you actually deploy it into your organization, you might find out that in actuality, that's not the case. So, you might have these cases that occur because of the unique aspects of your patient population. So that's why you need to consider testing for those types of cases that are representative from your organization. And you also need to consider the fact that you have to monitor your algorithm and make sure that your clinicians are aware of its limitations and understand when to report when something is reached where the clinician feels that the technology no longer supports, for example, decision making or a particular process. And that should be okay, because that allows us to improve the technology and the algorithm, and then we set the bar a little bit higher, and eventually there'll be fewer instances of issues.
Wonderful. Thank you both so much. Those are all of the questions that we have. I have no doubt that people will be reaching out to the both of you to contact you, to learn more and to gain more insights into your research. So we will close this session, the last session of the day. We'll bring the poll up to get some feedback on the session. And just once again, much appreciation to yourself, Andre and Elizabeth, for joining us today. As all of us sort of wrap up for day 2 of the BC Digital Health Forum, I certainly want to take an opportunity to once again thank all of our phenomenal presenters, certainly our interpreters and captioners who have been working tirelessly throughout the day to support our audience, and of course the audience that has shown up. We have had an incredible turnout throughout all of our sessions today, and we've had a great day of learning and really exploring how digital health can not only help us improve patient outcomes, but revolutionize how we approach care and well-being. That's really exciting. To look forward to seeing many of you tomorrow for our hybrid event, which takes place both virtually or those of you joining in person at the BC IT Tech Collider space in downtown Vancouver. All of the sessions will be broadcasted online, so please feel free to join virtually if that works best for you. But we do hope to have a great virtual turnout as well. And lastly, before we close all of the above, we encourage you again just to explore the website. I checked out the gamification happening on there. There's a couple of people that are in top line for first place, but we're only on day 2. So just encourage you guys to take advantage of those. Once again, thank you all for an incredible day 2 of the 2023 BC Digital Health Forum, and enjoy a fantastic evening.